we're good.
Okay. All right, so my name is Gareth. You're watching the Hub Online Network, and today we are joined by MLA Jackie Tegart and President of the HAWC, or the Health and Wellness Action Coalition in Ashcroft and area, Sheila Cornelli. So how are you both doing today?
Great, and thanks for having us today.
Thank you.
My pleasure. So why don't we let Sheila sort of start us off with what the topic of conversation is, and then we will go from there.
Sure. So, Healthcare and Wellness Coalition has been at it for a long time. I've been working with them for 3-4 years now. Last fall, we were making some good progress with Interior Health. We had a change of managers, which was a breath of fresh air for the new people that were coming in. A new manager was hired locally, lived locally, and worked at our site. And that was, we were making good progress with talks with them. And then COVID happened. And so we let them do what they do, and we just sort of stayed back and just kept an eye on things as we usually do. And so what we discovered was that the lab was starting to be dismantled while COVID was happening and nobody was really around to hear what was going on. And so we started up conversations again with Interior Health managers. Despite the fact that they're busy, they did respond. And so since then, we've been in some good communications with them regarding the healthcare model that we have now and the promise that the NDP made for a 24/7 ER during the election. They told the community and publicly announced, and I think it was actually on your show, that they were going to, if they won, they were going to provide 24/7 ER for Ashcroft. So we thought that it was a good time to start having that conversation about that promise and what did that mean and how to go about doing something about what's happening at our health site, which is being dismantled slowly. So we got a hold of our friend Jackie Tegart, and we had a conversation, got together with Interior Health and began to talk about how do we go about using that promise, leveraging it, if you will, to get a healthcare model that is actually going to look after the people of this community and be consistent and sustainable. And so then Jackie had some suggestions about how to go about doing that, and she can talk about the politics of that piece.
That sounds like a great segue. Jackie, what are the politics of that?
Well, certainly it's unfortunate that healthcare is political, but to have a group like the group that Sheila leads in our community is a real asset. Anytime I've made any move towards advocacy at the provincial level, the Minister of Health is very well aware of the group here in Ashcroft and the work that they're doing. And so I felt the same way as Sheila said. When the promise was made during the election, it gave us leverage to approach the government and approach Interior Health about how we put that promise into being in the community. And I think it was a great opportunity for us to work together with Interior Health and the HAWC group to really be clear about what the community needs are and to put together a model that's sustainable. The first thing I did was I met with the CEO of Interior Health, and in that meeting put them on notice that we had been given this promise as a community and as a region, and that we would be pursuing a model that works for the community. And what that model looks like, it was through Sheila's group that we had those discussions with Interior Health, and those discussions are ongoing. But I want people to know that we have not forgotten that promise, and we are really pleased with the willingness of Interior Health to have meaningful discussions with the community through Sheila's group and others to talk about what the needs are here and what the model is going to look like.
So just to add some context for people that are watching, what Well, you use the term dismantling, Sheila. What does that actually mean? And specifically in the lab, because like I know what's going on, but maybe other people don't. So can you explain to us what's happening at our local health site?
Well, it's a bigger picture than just the lab. The lab is just one of the pieces that's happened, in our opinion, almost secretly, because nobody really is hanging around the health site now. Nobody wants to be there. And so removing, the lab techs, as they've retired, they have not been replacing them. So they're not recruiting. And when I say they, I just need to clarify. The people that we're working with, the local manager and their leaders, have been exceptionally good with us. It is the lab managers who work in a different silo that have been dismantling the lab. And it is because they can, and because they see a weekend only ER as something that they don't want to support in the model that they have been. So they're giving a, it only get into all the terms, but it's called point of care testing that they're using, which is a small machine that's in the ER, and it takes blood from the patient. The nurse has to do that work. Lab techs are no longer there to do that. And they can run some tests with that blood work. Anything else, if a urine specimen or any other types of specimens that are taken, does not work on point of care. So those things get what they call hot shotted to Kamloops, to Royal Inland. So that's an expensive little way to say that somebody drives out, picks it up and drives it to Kamloops, and then it gets tested, and then the results are called back to the ER. If they require other tests to be done, the patient has to be transported to Royal Inland to get the extra tests done.
Okay.
In addition to that, they started removing some equipment from the lab. So the work can't be done in the lab now. So the chemistry analyzer was removed, for example. They've removed the blood storage from the facility. So transfusions can't be done at this point, as far as we understand. And in addition, because some of those things have been removed, there is still one lab tech left that came back from a sick leave, and I don't think they were expecting that. And so she's not able to run the test that she normally would. So she's actually, from what they tell us, using point of care testing in the lab on outpatients during the week as well. So that's our opinion, that is a secondary level of service, and it doesn't properly support emergency room services. If it did, it would be in all emergency rooms, and no, there wouldn't be any labs anywhere.
So if that's what they're doing, what does that look like in terms of real world jobs and not filling spaces?
Are you talking about recruitment and retention, or?
Yeah.
Yeah. Well, they've recruited a full-time lab assist. So there's a difference between a lab tech and a lab assist. Lab assist is probably the one you would have met in the lab in the last probably year or two. She's the gal at the front, doesn't have to be a woman, that draws your blood and prepares it, puts it in the tubes and prepares it. If there's a lab tech on site, she passes that on to the lab tech, who then runs the tests that need to be done on it. Okay. If there isn't a lab tech on site, she packages it all and sends it all off to Royal Inland at the end of the day.
Okay.
So, and on top of that, so that's just the one piece, but the ER is is one that's been torn apart. It's taken 20 years to dismantle our healthcare site. So it didn't just happen overnight, but the ER on weekends only was the biggest hit that we took. And we know that they're struggling to keep it staffed. We know that it's costing them a fortune to run it for 2.5 days a week. And it's not serving the community. It's not doing what we need it to do. The nurses have a rotation that is not the envy of anyone. I mean, nobody wants that kind of rotation working weekends only. And so to retain those nurses, to recruit new nurses to replace the ones that go, is a real challenge. So that's the biggest pieces. And there's a final piece to it, which is the physician group. So the physicians have been coming in under the practice readiness assessment program, which means that in most cases, they are from out of country, but they've been in Canada for a little while, and they sign up to to go into this program. And it's a training opportunity. They write some exams, they get some mentoring from Canadian physicians. And when they're ready and they've passed all the tests and stuff, they finish out the rest of that time in an assignment that they agree to. So in our case, they would come to Ashcroft, and they are under an agreement called return of service, where they're required to finish a 3-year term. And in that term, they still are getting all of the qualifications and getting ready to be a fully fledged qualified physician in Canada. What we've seen at the end of the 3 years so far is they leave. And in a sense, we understand that. Like, that's their lifestyle they're looking for and whatever else they want to do. The problem is that nobody plans for their departure. So in our case right now, we had a third physician that suddenly disappeared, and it's a little bit vague about what happened, but he wasn't happy. Let's just say that. So we have 2 physicians. They aren't taking on any more patients. They've reached their capacity, so people are being turned away. One of them is very close to reaching his return of service agreement. But there is no plan for A, replacing him if he goes, because he hasn't told us yet, and B, to fill that other spot that's vacant. So we see ourselves probably, and it's happened before, down to 1 physician. And that's not sustainable either. And that's a business, that's a business model. That's their own business. We don't have any way to define what they do, how they do it, or any of that stuff. So we think a different model that isn't a private business is one that we should look at to see whether or not that solves some of our problems. We need to know how long a physician is going to stay, and we need sufficient notice when they go to replace them with somebody else.
When is this physician's time actually up?
I'd be speculating on the date, but it's coming up soon. That's all I know.
Okay, so that being said, then let's take a step back to something that we've already mentioned, is the NDP's promise to have an actual 24/7 hospital. Okay. Now, first of all, before we get into what that actually means, what did you guys both think about the fact that they said that in the election? Like, when you heard that, what was your thought?
I called up the candidate for our region and asked him on what basis did he come up with that promise? Who suggested that was the solution? Because it certainly wasn't us. So he said that he talked to members of the community, and that's what they said they wanted.
Right.
Perhaps that's true. But I began to explain to him, much the same way that I'm explaining to you now, why a 24/7 ER is not the solution we're looking for. It's not sustainable. If we agreed, let's just say we agreed to do that because they made the promise, and we said, sure, let's get a 24/7 ER going. We wouldn't be able to recruit to it. We wouldn't be able to keep it sustained, and it would fail. And then the NDP would have made their promise, kept their promise, and we would end up with a mess that we would basically lose the health site, in my opinion. We keep our long-term care and, hobble something together. So our conversations with Interior Health were, we've always said that we are looking for a 7-day healthcare model from the beginning. Our first petition, that's what we said. Consistent, sustainable, 7 days a week, extended hours. And so that's the conversation we're starting to have now with them. We don't know exactly what the model will look like, but we have an agreement with Interior Health, and through this area planning table that we all sit at, that they're going to fast track this model now so that we get it something within 2021. We're going to have a different healthcare model in our community that we will have gone out to the community and asked for their input. We want to know what they think we should have in there. And once we consult with Interior Health, consult with Interior Health and the community, I should say, then the model starts to get built. And Interior Health is ready to do that. And an expression of interest has been sent off to the ministry through the primary care network planning. There's a lot of red tape that has to happen, unfortunately. And so we've started that process, but we've been told that we're going to go ahead regardless of the red tape, and our friendly MLA is standing ready to help with any red tape that happens at the government level.
Okay, so what does it actually look like then?
Well, I think that Sheila's been very clear in the fact that it's not just one thing that could fix this. It is, if we lobbied for 24/7 ER, that doesn't fix our doctor problem. If we lobby for, like, what should the model look like? And Sheila's group did a lot of work over the last 2 to 3 years in regards to getting input from the community. And as she said, what they heard was 7 days a week, extended hours. And so we have Interior Health in a place where they're very willing to have a conversation about what a model might look like. We have a promise from government that we can leverage and go to the minister and the premier to say, we've talked to the community and this is the model that people have agreed upon. We have Interior Health, who is being extremely cooperative and are at the table and wanting to move this forward as quickly as possible. And personally, we have a goal to have it done in 2021. So I'm excited. I am willing to do what it takes to knock on the doors to, once the community has clearly identified what that model might look like, to take it to the people who make those decisions. And it's great to be working with the community group, with Interior Health, and with me as the MLA together to move this forward.
One of the things, so after the election happened, so Aaron Shumahetsa, the NDP candidate, makes the promise for the hospital. He loses. One of the things that sort of came up with me as I'm out in the boat was now that he lost, the promise is moot because it was an NDP promise. Is that a legit worry for people?
Not for me at all. The NDP won, and they won quite significantly. So,
except for in the riding where the promise was made.
Yes, but Premier Horgan told Aaron that that was a promise on behalf of the NDP.
Okay.
And it's my belief that we have every right to expect that they will deliver. And so when we look at the cost of the ER for weekends, and we look at developing a model and moving that forward to have a decision made to adopt that, I think that we have really good leverage based on that promise. So once the community comes to an agreement and we are moving it forward, my job as the local MLA will be to, if we run into barriers, is to make sure that we move those barriers and that we get the solution that the community is looking for.
Okay. So between the two of you, if everything moves forward without a hitch, okay, and you guys are talking about many different things that could happen and whatnot, in your opinion, what would be the best thing that could happen by the end of 2021 for our health site if everything just fell into place?
Well, I just want to clarify something first, because I'm not sure if we've misrepresented what we're saying, and that is that the promise of the NDP is in our back pocket. Okay. And that our discussions with Interior Health are that this makes sense to do, to change the model from what it is to a 7-day-a-week, sustainable, extended hours healthcare site. And there are examples of those kinds of sites. And so there's a couple of different models that we'll be looking at. And so there's the Urgent Primary Care Center. There's an example of that in Kamloops at the front building of Royal Inland Hospital. Ours could be a similar model to that. And some of the work that's being done to prepare for discussions are getting input from that particular center. The other model is a community health center, which is a slightly different model, and it doesn't have an urgent care component to it. But it does come with some extra things that we want to consider, so we decide which model to go with. So we're not reinventing the wheel. We're using models that exist, and we're going to customize it, we hope, with the input from the community to the model that suits us. And the other piece is this isn't just Ashcroft, this is all of the area that's serviced by this health site. So Clinton and Cache Creek and Spence's Bridge and all of the First Nations communities within that catchment area, Wallachine and all those little communities. Loon Lake is another one. So the input has to come from all of them. What do they need? And then the model we believe is going to be built to suit that. We have a building and that's a plus. So we're not, we have a building we can work with, and that's one of the things Interior Health said, and it's got lots of space in it to change the model to get access to the spaces that are needed to do the kind of work. So we're not reinventing anything, but we're seeking input from the community about what it is, because we don't know all the answers. We do talk to the community, but with this real model looming ahead of us, we really need to talk to the people and find out what it is they need and see if we can't do that.
So what are some of the ways that you were planning on connecting with the community then?
Well, it's Interior Health is going to take the lead on this, and we're going to assist. So they have a team that will come out and they will set up meetings, and it depends on where we're at with COVID and vaccinations, how that looks, whether it's virtual meetings or whether we can have some in-person meetings we'll still need to do distancing and masks and things, but we might be able to have a smaller size group together. That still has to be determined, but there's a team that will come out and we will be working with them. So we'll be sitting at those tables, we'll be in those discussions with the community, with Interior Health. There may even be a physician component to it, not necessarily our local physicians, but someone representing physicians at the table. I'm not sure what they'll put together, but that's what it will look like.
Okay. One thing about COVID is, do you think that COVID might have made this process easier or more difficult in the long run? Or is it a factor at all?
Well, I think that COVID has taught us a lot. And so when we look at healthcare models, we know that some things that we had to use and do out of pure necessity because of COVID, we want to adapt and adopt and use it in a healthcare model. So virtual visits, for example, has been the only way almost that you'll see a doctor. Occasionally you can see one in person, and occasionally they'll put their hand on you. But specialists and pre-surgical screening and all those types of things can be done with what was called telehealth, we now call virtual. And so incorporating a large component of that sort of capacity in not only our site, but even in our almost satellite site in Clinton that we support from this health site, that they can access a doctor virtually with a nurse at the site in Clinton and get the same kind of care as if they drove down to Ashcroft to see a doctor. So we just have learned lots of things. I can't think of anything other than living with COVID over our heads. I can't think of anything that has been a negative, except that the lab got pulled out from under us.
Okay. Is there anything else you guys would like to say about this?
Well, I think that I'd like to acknowledge the work that has been done in the community. I think all of us who have I think everyone has an interest in healthcare and how it's delivered. And as we look at, as Sheila said, going through COVID, we've had many, many discussions about virtual healthcare and how to integrate virtual healthcare. And people have been uncomfortable with that. But because of COVID, we've seen a necessity of using virtual healthcare. And I think that it has a place. It will never replace the actual patient-doctor relationship. But we've learned that it could have a place in a healthcare setting. So I think that we're in an excellent position to really look at the healthcare as a whole, not as silos. And as Sheila talked about the lab, someone makes a decision on a lab and doesn't think about the big picture in our community. someone makes a decision on some other care at the health site and doesn't take into the big picture, you know, what it might mean. So this group that Sheila leads looks at healthcare holistically, looks at how do we bring everything together. And I can't help but say that I'm excited about moving forward with the process, hearing from the community, and hopefully looking at a model that we will see in this year.
Sheila, just for the sake of doing it, can you tell us a little bit about what your group does specifically, and how people can connect with you if they were interested in showing support or give you suggestions?
Well, first of all, we meet once a month, and we've been doing that virtually since COVID began. And so anybody's welcome to join that. We have a Facebook page where people can indicate an interest. We have an email address where they can contact us if they want to join, if they want more information, if they want to tell us a story. We also have a website that is it's open, but we're still working on it. We're trying to create a patient navigation place for people to know where to go when they need certain types of healthcare, starting with that document that Ontario Health gave us back in the fall of 2019, where they said, these are all the services that are available here. Well, we're trying to prove that because we don't believe some of it. And so we're trying, and when we do prove it, then we create the navigation on the website for people to do that. And that's been a long term project, and none of us are great techies, so it's been taking a little while. So there's that way as well. And we will be getting to put notices out when these meetings are going to happen. We're waiting for one of the leaders from Ontario Health who's recently had a surgery. She needs to recover, and she's an important part of the team, and so we're willing to wait for her. Not that we have a choice, but I mean, she's really supportive, and she's great to have on our team. So when she's ready, we're ready. And then when we go out there, people will find us easily that way as well.
Okay. Awesome. And how can people, are you taking emails on this as well? Can people
Absolutely. People can email or telephone my office here in Ashcroft. And we're working as a team, and we'll be sharing information, and we really encourage people to be a part of this process. It is really important that these discussions reflect what the community wants and what their expectations are. So we're looking forward to Interior Health setting dates for that input, and very much plan on being a part of that.
Awesome. Well, very cool. So unless there's anything else you'd like to say, Sheila.
Yeah, I want to add one other thing, and that is that, you know, we've been through this for a long time and we've learned some things. And so the other thing that we've asked Interior Health is that we want to plan also for an ongoing, whether it's a working group, a steering committee, or some form of community involvement in the healthcare facility itself, so that we don't end up in the same situation we are right now. And they see some value in that as well. There is a model that we had based our thinking on, which is the Princeton model, where they did create a steering committee. Interestingly enough, in another meeting I was in the last week, that steering committee, they're feeling it's not working. And that's the local group. So Jackie, I don't know if you even knew that yet, but they found that what it's turned into is Ontario Health just speaks to the people and then they leave. So that won't be the model we're looking for now. So we'll have to invent something. But it's important not to just say, okay, it's fixed, good, we're done, and walk away, because we'll see the same thing happen again.
Right. Well, as things change, hopefully this opens up the dialogue between you guys and us, because we would love to be up to date and share what you guys are doing with the public. So hopefully we can set something up in a few months and see if there's an update.
Sounds good.
Right on. Well, thank you both for your time. I appreciate that. Anybody at home, if you have something that you want to say, we will put the email addresses and stuff on this video and in the description of this video. You can also send emails to myself at honjournalist@ashcrofthub.com, and we will go from there. So thank you, Sheila. Thank you, Jackie, and we will catch up with you guys a little bit later.
Thank you so much.